Good evening to everyone. This is Nitish from Medusane. Today we'll be having a case presentation on bronchiectasis by who will be Dr. Yogesh sir will be guiding this whole session. Dr. Yogesh sir is the assistant professor of internal medicine in Madras Medical College, and the presenter is Sumaya Fatima from Chengalpet Medical College. I'll give the session over to you, Sumaya.
Good evening, everyone. This is Samaya from Chengalpet Medical College. I'm a final year MBBS student. Today, I'll be presenting a case on bronchiectasis. Shall I begin, sir?
Yeah, good evening. Good evening. You can start.
A 52-year-old male Murugan, address from Kanungal, daily laborer by occupation, from upper middle class family according to modified Koppusamy scale. Chief complaints, coughing blood for the past 8 days. History of presenting illness. The patient was apparently normal before 1 year, after which he developed cough with expectoration, chronic duration, intermittent in nature. It's a wet type of cough associated with variations in night and seasonal variation in winter. It's aggravated by upper respiratory tract infection and relieved by medication. The consistency of sputum is mucoid. It's not foul smelling. It's 50 milligram per day. The patient has hemoptysis of acute duration of 8 days, which is gradual, and the quantity is 300 ml, red and fresh in nature. It is odorless. It's not mixed with food particles, and it occurs every other night time. History of weight loss is present. No history of night sweats. No history of evening rise of temperature. No history of loss of appetite. No history of hoarseness of voice. No history of difficulty in swallowing. No history of chest pain. No history of dyspnea. No history of wheeze. No history of fever. No history of leg swelling. Past history. History of similar episodes of blood in sputum 4 months back. He's a known hypertensive. He's a not known case of diabetes, bronchial asthma, epilepsy, and tuberculosis. Personal history. The patient is not a smoker. He doesn't consume alcohol. He has normal bowel and bladder habit. There's no similar complaints in the family. Socioeconomic history. The patient is class 4 according to the modified Koppusamy scale. Treatment history. The patient is on drugs for the past 12 years. A 50-year-old male who is a known hypertensive admitted to the ward with complaints of cough for a long time, hemoptysis for the past 8 days, with history of admission for hemoptysis 4 months back. The patient is on drugs for the past 12 months. Based on the above symptoms and finding, the system involved is respiratory system. The possible site could be airway or parenchyma.
Okay. So can you go back to the history slide? We'll have a short discussion since this is the first case of respiratory system.
Yes,
okay, fine. So coughing blood for the past 8 days, right?
Yes,
so
sir.
what do we call this as?
Hemoptysis, sir.
Hemoptysis. Okay. So how will you differentiate hemoptysis from hematemesis? Can you differentiate some 2 or 3 points?
So hemoptysis is going to be frothy, sir. The pH is going to be alkaline, and it's going to be red in color, whereas hematemesis is going to be mixed with food particles. The pH is going to be acidic, and it will be mixed with food particles.
What will be the color?
Color will be dark red, sir, because of acid hematine formation, sir.
It will be
And
mostly brown colored, chocolate brown colored,
chocolate brown color.
because your acid in the stomach will neutralize all the RBCs and hemoglobin. So hemoglobin will be acidified.
Yes,
So
sir.
it will be like dark brown colored. So that is how you differentiate between hemoptysis and hematemesis with just history with the color.
Yes, sir.
All right. So your patient is having hemoptysis for the past 8 days.
Yes, sir.
Right? Okay, fine. Can you go to the next slide? Okay, fine. So whenever you are asking the history of hemoptysis or cough, what are the important histories to be remembered?
So whether Whether the hemoptysis was preceded by cough or nausea or vomiting to differentiate it from hematemesis, sir.
Very good. Then,
Yeah, and whether it was precipitated, patient has a respiratory problem, or the patient has a previous history of any like peptic ulcer or something, sir.
okay,
And uh,
fine. Okay,
and the, mm,
okay. So, can you elaborate about your patient cough alone? Cough.
the patient is having cough for a long like as patient says like he remembers cough from the like from a long time like 10-20 years, sir, and he's
Hmm.
having a very wet type of cough, uh which he describes as it's not purulent, it's just mucoid in consistency, and the cough aggravates mostly at night times and during winters, and it's relieved mostly by medication, sir.
Okay. So, can you tell the different types of cough?
Yes, sir. And we have a bovine cough, which is loss of its explosive nature when a tumor on the recurrent laryngeal nerve presses. And we have barking cough in epiglottal involvement. And we have paroxysmal cough in viral infections, we can see, sir.
Very
And
good.
we have a suppurative cough, which we can see in parenchymal lung disease. And we have
Excellent.
dry cough, which we can see in interstitial lung disease, pleural pathology, and some mediastinal lesions, sir.
Excellent. Very good. Very good. So, now you have differentiated the cough, how it is started, what is the duration, and what is the progression. Am I right?
Yes, sir.
So, this is of a longer duration. Almost you are telling about 20 years. So, it is of chronic etiology. Am I right?
Yes, sir.
So, what are the causes of chronic cough?
Interstitial lung disease, sir. Chronic obstructive COPD, sir.
Very good. Yes.
Mm, bronchial asthma.
Very good. Then,
um, Cystic fibrosis.
okay. Now we are telling everything about the respiratory system. Are
Yes, sir.
there any causes of chronic cough other than respiratory system?
Mediastinal lesion, sometimes mediastinal
Okay. Anyway,
lesion.
that also comes under the thorax, no?
Mm.
Respiratory system. Anything
Left,
else apart
left,
from respiratory system?
left-sided heart failure, sir.
Very good. Yes. Anything in GI, gastrointestinal?
Esophageal motility disorders.
Very good. Yes. Then,
Um, Aspirations, recurrent aspirations.
yeah, that is one of the pathogenesis. But what is the etiology?
Mm.
Reflex something.
Achalasia cardia.
Reflex disorder. What is the reflex disorder? Gastroesophageal reflex disease.
GRD.
Okay. Yes. So GERD is once again a common etiology for chronic cough, especially the nocturnal cough.
Okay,
Okay.
sir.
So whenever you try to ask history of chronic cough, you should always see other system which is getting involved. So that is more important because you are seeing the patient as first time. You should not go with it's a chronic cough, so I am dealing with respiratory system. So you should always rule out other system causes for chronic cough.
Okay, sir.
Able to follow?
Yes, sir.
Right. Okay. Then you move on to the expectorant. Your expectoration is again for how many days?
Uh, Along with cough, there's expectoration, sir. The patient is, as long as he's having.
So 20 years he is having expectoration also.
Yes, sir.
Okay. Can you tell the color of sputum? Different colors of sputum?
Um, uh, Sir, rusty sputum in pneumococcal pneumonia, sir. And
Hmm.
red currant jelly sputum in Klebsiella pneumonia, sir. Black color
Okay.
sputum in cold worker pneumoconiosis.
Okay.
Green color sputum in bacterial infection because of
Hmm.
myeloperoxidase, that enzyme is imparting that color.
Very good.
Uh, uh,
Fine. Okay. Okay. So your patient is having any discoloration of your sputum or it is just white in color?
it's white in color, sir.
What type of color do you get in bronchiectasis or bronchial asthma?
Sir, mucopurulent sputum will be there in bronchiectasis, sir.
Yes. Yes. Bronchial asthma.
The mucoid in consistency, sir. Wrong.
Consistency will be mucoid. Any color, it will be fresh white color. Bronchial asthma. And if you have the 3 layers of sputum, am I right?
Yes, sir.
So, or can you tell the 3 layers of sputum?
Sir, I cannot remember it right now, sir.
Okay, fine. So, in which type you get that 3 layers of sputum? In which condition? So, in
Bronchiectasis.
bronchiectasis, you get that. Is it bronchiectasis or bronchial asthma?
Bronchiectasis, sir.
Bronchiectasis.
Yes, sir.
Okay, fine. Next, did your patient have any breathlessness or dyspnea on exertion?
No, sir.
He did not have.
No, sir.
Okay. So, what is the current system we follow for the breathlessness?
MMRC grading system, sir.
Okay. So, how many grades are there, and can you tell the different grades of MMRC?
So the grade ranges from 0 to 4, sir. The grade 0 is like dyspnea on strenuous exercise. Grade 1 is dyspnea on hurrying on the ground level or walking a short hill. Grade 2 is dyspnea uh, dyspnea on the ground level with the people of the same age. Grade 3 is like dyspnea on walking 100 meters. Grade 4 is like too breathless to dress up or go out, sir.
Okay, fine. So your patient doesn't have any uh, breathlessness. Am I right?
Yes, sir.
Okay, fine. How will you differentiate respiratory breathlessness and cardiovascular breathlessness
Sir,
through your history?
Sir, dyspnea on exertion points more towards cardiovascular system, sir.
Okay, okay. So how to differentiate? Are there any differentiating features between the both? Two important histories you need to ask. Whether the patient is having orthopnea and the patient is having paroxysmal dyspnea. So these two histories are very, very important to differentiate between the cardiovascular cause and the respiratory cause. Okay, so if at all your patient is having breathlessness, you need to tell whether it is present or not in order to tell whether LV failure is present.
Okay, sir.
Okay, fine. So can you proceed?
Yes, sir.
This slide. So you have asked all the negative histories.
Yes, sir.
Am I right?
Yes,
So
sir.
history of night sweat, history of evening rise of temperature, history of loss of weight and appetite. So why you have asked all these histories? Is it relevant to your history
Yes,
or
sir.
your case?
To rule out tuberculosis in the patient, sir.
Okay. So any chronic cough of more than how many months you need to rule out tuberculosis?
3 months.
Now it is 1 month. Current guideline says 1 month chronic cough, you please rule out tuberculosis. Okay. So weight loss, night sweats. Why that night sweat is coming here? What is the importance of night sweats?
It will, because of this inflammatory cytokines released, sir.
Okay, that is one. Always you should rule out bronchogenic carcinoma. Okay, whenever you are dealing with respiratory system, you have to rule out
Bronchogenic
carcinoma. So always it is one of the symptom of malignancy. Especially we ask those things for ruling out malignancies and tuberculosis. Okay, so that is the importance of night sweat and weight loss with loss of appetite. And then no chest pain, no dyspnea, no wheeze, no fever. Why you have asked the leg swelling? What is the relevance of leg swelling?
Sir, Lung pathology, like because of the chronic sputum release, proteins also might get lost, sir. Because of hypoproteinemia, we can get leg swelling, sir, or it could be because of cor pulmonale also, we can develop leg swelling, sir.
Okay, so can you tell what is cor pulmonale or definition of cor pulmonale?
Sir, it's a right heart failure because of a non-cardiac cause, sir. It's because of lung pathology.
Okay, due to chronic lung pathology, the right ventricle goes for dysfunction, leading to pulmonary hypertension and right heart failure symptoms. Okay, so that is cor pulmonale, and the patient will be presenting to you with leg swelling as well as breathlessness. Okay,
Yes, sir.
so that is the importance of leg swelling in your case. Can you go to the next slide? Okay, so initially I told you need to rule out gastrointestinal causes of chronic cough. So you should include history of dyspepsia, history of regurgitation after eating, okay, nocturnal cough. So all those things you need to add to rule out gastrointestinal causes of chronic cough.
Yes, sir.
Okay, so that part is alone missing. You just add it. And past history is he had similar episodes of blood and sputum 4 months back. So the same symptom he was admitted 4 months back also. That is
Yes,
what you are trying to tell.
yes, sir.
Okay. So can you tell what is hemoptysis?
So, coughing up of blood is hemoptysis, sir.
Okay. So what are the different grades of hemoptysis?
So, mild hemoptysis is between 50 to 100 ml, sir. Moderate is between above 100 to 150, sir. Severe hemoptysis is above 200, sir. Massive hemoptysis is above 500 or 100 ml, 150 ml loss per hour or 100 ml loss for the continuous 3 days, sir.
Okay. So can you tell a few causes of hemoptysis in respiratory system?
Bronchogenic carcinoma, lung abscess, bronchiectasis,
Hmm.
empyema.
Okay. Why
And
do you think blood should be coming along with sputum in all these respiratory causes?
so the arteries will be there.
So what is your blood supply of your bronchus and bronchioles?
Pulmonary artery.
Pulmonary artery or bronchial artery? Pulmonary artery is going towards, where is it
Alveoli.
going?
Alveoli.
Okay. So mainly you have the bronchial artery and bronchial vein. So when you cough more, right? So
Yes.
all these minute blood vessels of your bronchial vein, they get, no, what happens? All they start bleeding. The small veins in your bronchial walls, no, they start to bleed. So that is the reason. This reason is common for everything. But when you tell individually, like tuberculosis, why does it bleed? Bronchiectasis, why does it bleed? You have different etiologies for that. Okay. So I'm just telling the common cause for this hemoptysis when you cough out very explosively, right?
Okay, sir.
Fine. Can you go to the next slide? Was he a smoker?
No, sir, he's not a smoker.
Okay. So in respiratory system, what is the importance of smoking?
So they are more prone to bronchogenic carcinoma, sir. There's a
Okay.
chronic
Are
smoke.
there any index where you can calculate and tell the risk stratification?
Uh, smoke packing years.
Pack here and smoking index.
Okay,
Okay.
smoking.
So pack here is number of cigarettes smoked divided by,
Number of
can you tell,
years.
number of
Years.
years into You have something to multiply, right?
12
What is it? 12? 12 or 10 or 20?
months, sir.
That's not months. So one pack, it will be like 10 cigarettes. Okay, in Western. And here they have 20 cigarettes. So you just, based on the locality, you have to multiply it number of cigarettes per pack. Okay.
Sir.
So that gives you a number. Anything more than some number is significant. Can you tell what is the number? Pack here.
20.
Anything more than significant pack here.
20,
Okay.
sir.
Okay, that is your homework. Okay. So you just calculate the pack here and then you stratify the risk for getting the bronchogenic carcinoma. Okay. So that is one important score or number where you need to calculate, especially in respiratory system. Okay. So that is very, very important. And is he an alcoholic?
No, sir, he's not.
Is not an alcoholic. Okay, fine. Any family history, relevant family history?
No, sir.
Do you think any family history is relevant in respiratory system?
It's if they have IgA deficiency, like hypogammaglobulinemia, some repeated infection among the family members, they could immunodeficiency disorder. Because of this, the person may be prone to some infections and is getting chronic cough.
Okay. One
Then
important cystic fibrosis.
cystic fibrosis.
Okay. The cystic fibrosis, you need to always ask the family history, right? And any environmental history is important in respiratory system.
Overcrowding and places where there's a lot of pollution, easy spread of infections will be present. So overcrowding.
So there are 3 to 4 important environmental history where you need to ask history of farming, coal mine workers, and then people working in this gas industry or asbestos industries. Okay, and some sugarcane factories, people working in sugarcane factories. All these are very, very important, especially all these can have different types of parenchymal or interstitial lung diseases. So the environmental as well as the occupational history is very, very important.
Okay, sir.
Especially when you deal with the respiratory system. Right?
Yes, sir.
Can you proceed?
Yes, sir.
So your patient is having hemoptysis and you want to check the respiratory system. Possible site is airway or parenchyma. Why you have written airway?
Sir, in airway disorders also, like because of goblet cell hyperplasia, there'll be a lot of mucus production, sir.
Okay, fine. And parenchymal, why you have written parenchymal?
So mostly pneumonia also will be having a lot of wet cough, like lung abscess pneumonia, like excess sputum production will be there, sir. So
But, do you think a 20 years duration will it be a parenchymal lung disease?
no, sir, I don't think so.
Less likely, right?
Yes, sir.
So probably you're dealing with
An airway disorder.
the bronchi or the bronchioles or the terminal bronchioles.
Yes, sir.
Yes?
Yes,
Okay.
sir.
So you want to detailedly examine respiratory system.
Yes, sir.
Okay, proceed.
General examination. The patient is conscious, oriented to time, place, and person, afebrile, poorly built and nourished, pallor present, no icterus, no cyanosis, clumping present, bilateral grade 2, no significant generalized lymphadenopathy, no bilateral pitting pedal edema.
Okay, we'll stop here. So can you go back to the previous slide? Yes. So your patient is conscious, oriented to time, place, and person. Okay. Now you are in the ward, right? Some patient who was on oxygen therapy suddenly went in for altered sensorium. He is not oriented to time, place, person. So
Yes.
what do you think it has happened to the patient?
He was taking oxygen during that time, sir.
Yeah, he was on oxygen therapy. Okay, maybe some 3 to 4 liters per minute. Some kind of respiratory disease is pre-existing. The patient is on oxygen therapy. In the morning rounds, the patient was conscious, oriented to time, place, person. Suddenly, when you go to the evening rounds, the patient was very drowsy, not oriented to time, place, person. So, what do you think the patient has got? And you need to actively intervene immediately.
Acute respiratory distress syndrome, sir.
Okay, could be, but why he has gone for disorientation? The question is why he has gone for disorientation.
Carbon dioxide narcosis.
Very good, very good. So CO2 narcosis or type 2 respiratory failure, where any kind of respiratory problem, the patient initially was conscious oriented, suddenly he becomes disoriented. You need to think of CO2 retention inside the body. Okay. So what is the immediate bedside test you want to do to confirm the diagnosis? Some gas analysis.
Arterial blood gas analysis.
So you take the arterial blood gas analysis immediately and see the CO2 level. If at all, if it is rates, you need to put him on a mechanical ventilator or a BiPAP or CPAP ventilation. Okay. To remove the excess CO2 from the body. So that is the importance of the consciousness and orientation, especially when you deal with respiratory system.
Yes, sir.
Okay. Then you told about pallor and pallor present.
Yes, sir.
Okay. Can you tell a few causes of pallor in respiratory system?
Hemoptysis, sir.
Okay, hemoptysis, right. When you have hemoptysis, what kind of anemia will be there? Is it microcytic or normocytic or macrocytic?
Normocytic anemia, sir.
Normocytic, because it's acute blood loss, so it is normocytic anemia. Okay, fine. Now your patient is not having cyanosis. Okay.
Yes,
So
sir.
suddenly, the same patient, what we were discussing, has cyanosis. Okay, central cyanosis, right? You do a bedside test or bedside examination in order to differentiate between cardiovascular and respiratory cause. Can you tell the bedside examination or bedside test?
ECG.
No, before that.
Hyperoxia test, sir.
So how will you do that?
So the patient should be given oxygen, sir, like
100% oxygen.
100% oxygen will
And
be
which will improve? Which system involvement will improve? Will the cardiovascular disease will improve or respiratory cause will improve?
Respiratory cause will improve, sir.
Okay, okay, fine. So that is the simple bedside test where you give hyperbaric oxygen and you look for resolution of cyanosis. Okay. So this is a very simple test which can differentiate CVS and RS cause of cyanosis.
Yes,
All
sir.
right. Clubbing, you have mentioned bilateral grade 2. Whether it is present only in the upper limb or lower limb or all 4 limbs?
Only upper limb, sir.
Only upper limb. So can you tell the grades of clubbing?
So there are 4 grades of clubbing, sir. The grade 1 is like loss of angle between the nail bed and fluctuation test is positive. Grade 2 is parrot beak appearance. Grade 3
No,
is
no, no, no.
drumstick.
Wait. You have little changed a little bit. So grade 1 is?
Loss of the angle between the nail bed, sir. Louis bond
Okay,
angle.
Lowy bond angle is lost.
Yes, sir.
Is that the thing or any test you want to do?
Fluctuation test will be positive, sir.
Okay. Fluctuation test will be positive. You fix the middle finger and then with your thumb and the index, you are going to fluctuate on one side and look whether fluctuation is present on the opposite side or not. So that is grade 1.
Yes, sir.
Grade 2 is you do the obliteration test. So that is how you need to keep, like, you keep the
Shamrods.
shamrods. That is obliteration of the nail bed angle. Grade 3 will be your parrot beak or drumstick. Both are same. Okay. Parrot beaking or drumstick appearance. Both belong to grade 3. Right. Grade 4 is hypertrophic osteoarthropathy. So, can you tell again a test which can differentiate between grade 3 and grade 4 clubbing? Simple bedside test. So, you just press over the wrist joint. When there is tenderness, then you think of grade 4 clubbing, because grade 3 and grade 4 will be having the parrot beaking or the drumstick appearance. Both are same. Okay. Then how to differentiate between grade 3 and grade 4? This is the very simple test. You just fix your wrist and compress it. And when you feel there is tenderness over the wrist joint, then you suspect grade 4 clubbing, and then you take a wrist joint x-ray. And when you take a x-ray, what finding it will be there in grade 4? There will be periosteal new bone formation. Okay. Periosteal new bone formation along the radial bone or the ulna bone. Okay. So you can just see some new periosteal bone formation because of this grade 4 clubbing. So that is how you can confirm by taking a X-ray of wrist joint. Okay. So this is the grades of clubbing. And can you name some causes of clubbing in respiratory system?
Bronchiogenic carcinoma, empyema, lung abscess, bronchiectasis,
Okay.
ILD, and
Okay, fine. You have almost mentioned everything. What is reversible clubbing or acute clubbing?
acute clubbing.
Hmm.
I
Or
don't get
reversible clubbing? Clubbing is usually a chronic pathology, right?
Yes, sir.
Chronic hypoxemia or any chronic hypoxia which leads to proliferation of your VEGF, you get all this clubbing. There are many theories.
Yes,
But
sir.
what is this reversible clubbing? So once when you treat the cause, the clubbing reverse. That is reversible clubbing, otherwise called as acute clubbing. Okay. So your empyema or your lung abscess, after the treatment, the clubbing disappears. That is called as reversible clubbing or acute clubbing. Okay.
Okay, sir.
Understood?
Yes, sir.
Okay. Can you tell what is pseudo clubbing?
So in a hypoparathyroidism, because of bone resorption, we'll get, sir. Because in leukemia and infiltration, we'll get it, sir. And in vinyl chloride workers also we can see, sir.
Okay. Any psychiatric condition you know?
Psychiatric condition, hysteria.
Okay, just find out. So
Okay,
there is
sir.
one psychiatric condition where the psychiatric child or the adult keeps on biting the hand, and all the digits will get resolved. Can you tell now what is the condition? It's called as arthritis mutilans. Okay, fine.
Yes, sir.
All the digits they start eating, and only the nail bed will be there. Nail will not be present. So this is also one reason for pseudo club. Okay, fine. Proceed.
No external markers of tuberculosis, no external markers of cor pulmonale, no external markers of HIV are present.
Can you tell the markers of cor pulmonale? What are the markers of cor pulmonale?
Elevated JVP, hepatomegaly, and bilateral pedal edema, sir.
Okay. So when you start from above, you have the elevation of your JVP, and then
Hepatomegaly,
right-sided hypochondrial pain
right side.
and bilateral pedal edema.
Yes, sir.
Okay, that is the markers of cor pulmonale. Can you name some markers of HIV?
Candidiasis, sir, oral hairy leukoplegia, Kaposi sarcoma, bacillary angiomatosis, psoriasis, seborrheic dermatitis,
Okay, okay. Tuberculosis?
uh, tinea versicolor, scrophaloderma, lupus vulgaris, erythema nodosum.
Okay, what is erythema nodosum? Very
So,
often you will be dealing with this erythema nodosum.
yes, these are red color patches, like rash-like, you'll get it, sir.
Hmm. Where?
On the arms,
Arms or palm?
arms.
You get red, as you told, red color,
Mm,
small nodular lesions, especially over the upper limbs you get.
yes, sir.
Okay.
Mm.
Erythema nodosum. Then anything else? Okay,
Scro-
proceed. Markers. There are no markers of TB, HIV, and cor pulmonale. Okay.
Vitals, pulse rate 84, 84. Rhythm is regular, no special character, no radial delay, no radiofemoral delay. All peripheral pulses are present, no vessel wall thickening. Respiratory rate 16, rhythm regular, type abdominal thoracic, temperature 37 degrees Celsius. Blood pressure recorded in left upper limb in sitting position 150 by 100. JVP is not elevated.
Okay. Any importance of pulse and respiratory system?
Sir, we'll get pulses paradoxes in acute exacerbation of bronchial asthma, sir.
Okay. Can you tell what is pulses paradoxes?
Sir, there will be inspiratory fall of BP by 10 mm.
Okay. So do you see pulse variation in pulses paradoxes, or it is BP variation?
It's BP variations.
Okay. I actually asked in pulse. Is there any pulse variations in respiratory system? I gave you a case scenario, right? For consciousness, orientation.
Yes, sir.
So what type of pulse you get in CO2 narcosis? You get bounding pulse.
Bounding pulse.
It will lift your pulse when you palpate the pulse.
Okay,
Okay,
sir.
bounding pulse. Okay, fine, proceed.
Examination of respiratory system, upper respiratory tract, normal mucosa, no nasal polyp, no nasal obstruction, oral cavity, poor oral hygiene, dental caries present. Inspection, chest wall is bilaterally symmetrical, kyphos is present, trachea appears to be in midline, apical impulse is visible, no widening of ribs or crowding, no hollowing or fullness of supraclavicular fossa and infraclavicular fossa, no drooping of shoulders, no dilated veins or scars, sinuses or tapping marks.
Okay, proceed.
Movements on apical anterior posterior on right and left side both are normal. Palpation, not warm, not tender. Trachea is in midline. Apical impulse in left fifth intercostal space, half an inch lateral to midclavicular line. Movements on either side, normal on palpation. Measurements, inspiration is 87, expiration is 83, chest expansion is 3. Hemithorax measurement, right-sided hemithorax measurement is 1.5, left side is also 1.5. Spino-scapular distance, right side it's 10, left side it's 9.5. Tracheal tug is absent. Inspiratory descent of trachea is absent. No tactile fremitus. Vocal fremitus is normal in all areas. On percussion, direct percussion over clavicle is resonant, cornec isthmus is resonant, tidal percussion is resonant, drop space is resonant, no shifting dullness present. On percussion, all the areas are resonant. On auscultation now, in supraclavicular fossa, on right side, we have mid-inspiratory coarse crackles. On left side, we have rhonchi. Infraclavicular fossa, we have polyphonic wheeze. On the right side, left side, mid-inspiratory coarse crackles. On mammary region, we have random monophonic wheezes. On left side, we have mid-inspiratory coarse crackles. On axillary region, we have mid-inspiratory coarse crackles. On left side, we have random monophonic wheeze. Infra-axillary mid-inspiratory coarse crackles. Left side mid-inspiratory coarse crackles. In suprascapular, both right and left side, we have mid-inspiratory coarse crackles. In interscapular region, both right and left side, we have mid-inspiratory coarse crackles. And infrascapular region, on right side, we have mid-inspiratory coarse crackles, and left side, we have random monophonic wheeze. Vocal resonance is normal in all the areas. Suction splash is absent. Point test is absent. Other system examination, cardiovascular system, S1, S2 heard, no added sound. Gastrointestinal system, normal bowel sounds heard, no organomegaly, CNS, no focal neurological deficits. Diagnosis, acute exacerbation of bronchiectasis.
Okay, fine.
Yes.
So can you go back to your inspection? Okay, fine. So the chest wall is bilaterally symmetrical. Okay. Can you tell few conditions where you get asymmetrical chest?
In scoliosis lesion and pectus excavatum, pectus carinatum, ankylosing spondylitis.
Okay. So what is barrel-shaped chest?
Barrel-shaped chest is seen in COPD, sir, where the anterior posterior and the transverse diameter is almost 1:1, sir.
Okay. So you are going to tell it is 1:1. What is the normal AP and transverse diameter
Sir,
ratio?
it's 5:7, sir.
5:7. Okay. And then you have told apical impulse is visible. There is no crowding. Where do you get crowding of ribs or
Sir,
widening of ribs?
so crowding of lips can be seen in collapse or fibrosis of the lungs, sir.
Very good.
Widening of ribs can be seen if there is like upper lobe collapse and lower lobe compensatory hyperinflation, sir. There we can see widening of lips, sir.
Any other common condition where you get widening of ribs?
Emphysema, sir.
Very good. So COPD, where you have emphysema or chronic bronchitis, you can have this widening of ribs. Okay,
Yes.
fine. Where do you get drooping of shoulder?
When there is a lung volume loss, lung volume loss is present, drooping of shoulders will be present, sir. So apical fibrosis or collapse.
Very good. Very good. Yes. So all these inspectory findings, no, at what position of the patient is important in seeing this inspection?
Sitting position, sir.
You have to make the patient to stand. Okay, always remember this rule.
Okay, sir.
Make the patient to stand,
Mhm.
examining straight forward the anterior as well as you go back and see the posterior aspect. Okay, then only you will be able to see whether there is drooping of shoulder. Okay, whether there is a movement of the chest at the back is present or not. Okay, whether there is crowding of ribs. All those things will be evident only when you make the patient to stand and you examine from the front and back.
Yes, sir.
Okay, this is a dictum for inspection of respiratory system. You have to make the patient to stand and look for all these signs.
Yes, sir.
Right?
Okay, sir.
Very, very important. In your exam, the examiner will definitely see whether you are asking the patient to make the patient to stand or not. Okay, then only the drooping of shoulder, the hollowing of the supraclavicular fossa, everything will be visible very clearly. Right?
Okay, sir.
Okay, palpation. trachea is in midline. So what is the method used for examining trachea by palpation?
The 3-finger method, so like 2 hands.
Three-finger method. Okay. Any other method you know?
No, sir.
Okay. What is tracheal tug?
Tracheal tug Oliver's sign, sir. We should stand behind the patient and we have to say the patient to lift their chin, and we have to place our both hands near the cricoid cartilage, and we have to say the patient to swallow. Like if we feel a tug during, sir, like it's because of aortic arch aneurysm is present. It if it's it could be false positive if there is a if it's like a thrombosis of aortic arch aneurysm, sir.
Okay. Partially right. Okay. What is Pemberton sign?
Sir, seen in retrosternal goiter, sir.
Okay.
We have to say the patients to lift both the hands, and we can see the congestion, facial congestion. We can see, sir.
Very good. Very good. So what is the mechanism behind that? Why
The
there is facial congestion
so
on
the
raising
retrosternal goiter compresses the vessels, sir.
the arm above the shoulder? What will happen? The retrosternal goiter moves behind and compresses your. What is there?
Mm.
Why there is facial congestion?
Vessels,
Which vessel?
carotid.
Carotid? What is there?
Trachea is there, sir, behind
Okay. Is there IVC there? IVC?
IJVs, internal jugular veins, sir.
Okay. So all mainly the SVC and its tributaries. Okay.
Sir.
So all the neck veins, no, it start to compress, and you can see the facial
Congestion.
plethora will be there whenever to make the patient to raise the arm above the shoulder. Okay,
Yes.
so that is especially you see a gross swelling here,
Mm.
and then you make the patient to raise the arm above the shoulder. Okay, so
Yes.
these are very very important sign where you can see any mediastinal mass or the thyroid gland, which is very visible whenever you inspect the respiratory system.
Yes,
All
sir.
right. Fine. Palpation, anything very important? Palpation, apical impulse is present in the fifth intercostal space. Okay. Can you tell some condition where you don't feel the apical impulse on right position?
Left side. Oh, sir, on emphysema, we'll not be able to feel the apical impulse, sir.
Very good. Very good.
Obesity behind the rib, we cannot feel.
Yes. Yes.
And if there is a mediastinal shift, we'll not be able to find the apical impulse in the usual location. It will be shifted laterally, sir. Little bit.
Can you tell one condition where you get mediastinal shift, acute condition?
Uh, uh, um, pneumothorax, pleural
Very good.
effusion.
Very good. Okay. Proceed. Palpation, anything else?
Measurements,
Measurements, everything is equal on both sides.
it's reduced, sir. Chest expansion.
Okay, fine. Fine, proceed. All these are okay. Proceed. Any vocal fremitus? How to do vocal fremitus?
We have to say the patient to say 1-1-1-1, and we have to like feel the vibrations on ulnar side of the
Which part you want to do in your palm? Which part you want to do for this vocal fremitus?
ulnar side of the palm, sir.
Ulnar side. Okay. For apical impulse?
Apical impulse also ulnar side, sir.
Okay. Then for thrill?
Sir, tips of the fingers.
Tips. Tips is usually done for what?
Pulsation.
Pulsations. Thrill is for the base.
Base.
Okay, base. Right. Proceed. Vocal fremitus is? Normal. Okay.
Yes, sir.
What is that chronic spelling mistake? Kronig. Okay. Chronic. It's not chronic, chronic.
Yes, sir.
Kronig. Okay. Chronic isthmus.
Yes, sir.
So can you tell the boundaries of chronic isthmus?
So medially is by scalenus anterior muscle, sir. Laterally is by acromion process of scapula. On anterior we have the clavicle. Posterior we have the trapezius muscles, sir.
Very good. Okay. What is the importance of this chronic isthmus? Why you have mentioned in percussion?
Sir, if we have any tumor occupying the apical position of the lung, we'll be having impaired or dull note will be present, sir.
Very good. Very good. Then any other resonance you get? Hyper resonant.
Hyperresonant condition.
Where do you get hyper resonance?
We'll get it in emphysema, pneumothorax.
Okay, very good. So that is the importance of chronic isthmus examination. And then you have mentioned no shifting dullness. Why you have mentioned that? No shifting dullness.
Sir, when air fluid level is a shifting dullness will be positive, sir.
Okay.
This
So do you think there is a water level and air level in your case?
no, sir, I don't think so.
Yeah.
The
So
patient is
that
not
can be
having
removed.
any difficulty or something, chest pain or something to
Yeah.
signify
There is
the.
no pleuritic type of chest pain. Okay. History is very clearly mentioned no chest pain.
Yes, sir.
So that can be removed and go to the next slide. Next slide. Next slide. You mentioned the coin test and
Oh, yes, sir.
yeah. Why did you mention that? Succession splash and coin test.
Uh,
This has to be mentioned only when you have a shifting dullness.
okay, sir.
Okay, so this also can be removed in your case.
Okay,
Okay,
sir.
now go to the percussion. Percussion, everything is resonant.
Yes, sir.
Okay. What are the different types of percussion notes you know in respiratory system?
So hyperresonant note will be seen in pneumothorax and in emphysema. Impaired note
Very
will
good.
be
Then
seen in fibrosis, collapse. Dull note will be seen in consolidation. Stony dullness will be seen in pleural effusion. And
very good.
boxy quality of resonance will be seen above the level of pleural effusion, sir.
Okay. What is tympanic resonance?
It will be seen on hollow viscous like stomach, sir.
Very good. Okay. So in your case, it is resonant.
Yes, sir.
It's not impaired.
No, sir.
Okay, fine. Proceed. Proceed to the auscultation. So when you go to auscultation, always you need to tell whether normal vesicular breath sound is heard or not. That is the first point you need to tell.
Okay, sir.
Okay. And then only you need to go to the added sounds or additional sounds.
Okay, sir.
Okay. So do you think coarse crackles, rhonchi, rails, all these are normal vesicular breath sounds or added sounds?
Added sound, sir.
Added sounds. So what you have missed here?
Normal
Yes, whether it is a vesicular breath sound or
bronchial breath.
vesicobronchial sounds or only high pitched bronchial breath sounds. Okay, all those things should come first, followed by all these additional or adventitious sounds.
Yes.
Okay, so that is more important because the examiner will wonder whether are you hearing any breath sound or not directly going into the additional sounds. Okay, so bronchial breath sound heard or you heard normal
Vesicular breath sounds only I heard, sir.
vesicular breath sounds? It was heard
Yes, sir.
in all the fields.
Yes, sir. It's heard, sir.
Okay, fine. So you heard mid inspiratory coarse crackles. Okay. What is that rhonchi? What is rhonchi and crackles?
Sir, we have continuous adventitious sound and non-continuous adventitious sound, sir. Rhonchi and V's are continuous sound, sir. Crackles is a non-continuous sound, sir. Rhonchi is a musical sound, sir. So it can be low pitch and high pitch, sir. If it's from a large vessel, it's high pitch. Low pitch, it's sonorous sound. From a small bronchiole, something, it's high pitch and it's called sibilant, sir. And
Okay.
of course, crackles is like it's not continuous and it's heard in in
Yeah, it
ID.
is. Yeah.
We have fine crackles and coarse crackles, sir. So
Yes.
fine crackles can be heard in ILD, pulmonary edema. Coarse
Hmm.
crackles can be heard in pneumonic consolidation, sir.
Yes. Yes. Okay. And bronchiectasis also. Okay.
Bronchiectasis, sir.
Coarse, leathery crackles. That is the usual description given for bronchiectasis.
Bronchiectasis.
Okay. Coarse, leathery crepitations.
Yes, sir.
Okay. Crackles or crepitations are same only. So do not confuse both.
Mm.
So it is coarse, leathery crepitations heard in that area.
Yes, sir.
Okay. So now we are mentioning supraclavicular area and then where else? Axillary, infraaxillary, suprascapular, interscapular on right side. So almost all areas you are having coarse leathery crackles.
Yes,
Am I
sir.
right?
Yes, sir.
Yes. On the left side, again, except in the supraclavicular area, all other areas almost having coarse crackles. Yes?
Yes, sir.
Okay. So what do you want to conclude by telling this presentation?
Sir, in because it's mid-inspiratory and it's a coarse crackle, which is most commonly seen in bronchiectasis, sir. So it's irreversible airway dilatation of bronchi and obliterative fibrosis of bronchioles, sir. So along with coarse crackles and wheezes are the most common finding when you auscultate, sir. So based on, and since all findings are normal, like percussion is normal, uh, vocal phlegmatis is normal. So there are few conditions where we get everything normal and only the auscultatory finding will be the only finding based on the history where the patient is having cough with sputum for a very long period of time, and the patient is having hemoptysis like again and again, so it may be a complication of bronchiectasis, sir. So I am suspecting bronchiectasis in this patient, sir.
Okay, fine. So what other features are favoring your diagnosis? Clinical examination finding favoring your diagnosis.
So there is reduced chest expansion, sir. It's only 3 centimeter. Normal, it's 5 to 8. So which indicates the patient is having a bilateral disease, sir.
Very
And
good.
the
Then
hemithorax is also very reduced, sir. So by this I can conclude this is a very chronic pathology.
one more thing. In general examination, you have one.
Clubbing, sir. Yeah, the
Yes,
patient
yes,
is
very
having
good.
clubbing, sir.
So grade 2 clubbing, you told no?
Yes, sir.
Definitely it will be grade 3 because of this chronic etiology. It will
Mm.
be like grade 3 itself. So clubbing with chest expansion diminished
Yes, sir.
with symmetrical chest indicates bilateral disease along with mid inspiratory crepitations almost all over the lung fields says this is a bilateral bronchiectasis.
Yes, sir.
Okay, and the patient is not in respiratory failure as per your
Mm.
case.
Yes, sir.
So this is a airway disease or a parenchymal disease?
It's an airway disease, sir.
Airway disease. So can you define bronchiectasis?
Irreversible dilatation of bronchioles and obliterative fibrosis.
Destruction and dilatation. So that should be your answer.
Yes, sir.
Irreversible destruction and dilatation
Dilatation of
of of
bronchi.
of
Irreversible and destructive dilatation of bronchi and obliterative fibrosis of bronchioles.
okay, of chronic etiology.
Chronic etiology.
And can you tell the different types of bronchiectasis? You know,
Um, so we have congenital syndromes with bronchiectasis, sir. Like we have Monier-Coombs syndrome, which is tracheobronchomegaly, and
Mm.
William-Campbell syndrome, which is bronchomalacia. And we have McLeod syndrome, which is seen in children because of repeated infection in childhood. And we have Brock syndrome, which is because of in tuberculosis, the lymph node compresses the bronchi. And because of this, we'll get middle lobe bronchiectasis, sir. That's
Okay.
Brock syndrome. And post-radiation also we'll get bronchiectasis, sir. Post-radiation
Okay.
fibrosis. On upper lobe, central bronchiectasis will be seen in allergic bronchopulmonary aspergillosis.
Very
Apic
good.
bronchiectasis will be seen in post-TB sequelae. And yellow nail syndrome, we can see Carter-Gunner syndrome, Young syndrome, immotile cilia syndrome.
Okay, you have mentioned almost all the causes as per textbook.
Yes,
So what is that Carter-Gunner syndrome? At the MBBS level, you should know this.
yes.
Carter-Gunner syndrome is
So the patient will be having dextrocardia, bronchiectasis, and sinusitis, sir.
sinusitis and motility dysfunction,
What do you do?
especially azoospermia or all the sperm count will be low. And the family history you need to ask, especially will be very, very thin built and tall built individual with azoospermia. They don't have a child. Okay, those that will be the history given. And since you have answered all the question, I'll ask one question alone in this types of bronchiectasis. What is dry bronchiectasis? Dry.
So dry bronchiectasis in or bronchiectasis sicca, it's seen in TB, sir, where there is only hemoptysis, sir, and the patient doesn't have cough with sputum production.
Sputum, not cough. There will not be sputum production. That is why it is called as dry bronchiectasis.
Yes, sir.
Okay. And what is that copious sputum? The typical sputum quality which is given for bronchiectasis is
Copious mucopurulent
yes,
sputum.
copious mucopurulent sputum. And what is that vicious cycle of bronchiectasis? Again, they can be asking you in the exam question.
It's because of some ciliary dysfunction, sir, there's going to be like impaired mucociliary clearance. Because of
Yes.
that, organisms are going to inhabit it, and we'll be having inflammation, destruction, and goblet cell hyperplasia, and mucus plug formation, sir.
Okay,
Again,
very simple. If you tell, it is like mucociliary dysfunction. There will be pooling of secretion. There will be infection, and again the cycle will continue. So this is called as the vicious cycle of bronchiectasis.
yes, sir.
Okay, very good. Proceed with your investigations.
So basic investigation, complete blood count, fasting blood sugar, renal function test, liver function test, chest X-ray, sputum. We have to see about the CBNAT, AFP, gram staining, culture of the sputum, pulmonary function test, and CT scan and bronchoscopy for the patient, sir.
Okay, so what we'll just quickly go through this. What you will see in CBC? What is the importance of CBC?
So since it's a very chronic pathology and the person has a recent episode of hemoptysis, we'll see reduced RBC count. So the patient will be having anemia because of that.
Yes.
And yeah,
Recent infection will show neutrophilic leukocytosis.
yes,
So that
sir.
is the importance of CBC.
Yes, sir.
Then what you will see in the chest X-ray?
So we can see tram track lines, finger and glove appearance because of the mucus dilation of bronchi. We'll see tram track lines, sir, and because of mucus plug is forming, we'll see finger and glove appearance, sir.
Will you see that in chest X-ray or CT chest? Finger in glove. Will it be seen in chest X-ray or CT
Chest
chest?
X-ray, I think we can see that, sir.
Chest X-ray, you will be dealing only with the cluster of grape appearance or the tram track appearance.
Okay, sir.
Okay. So the finger and glove, the signet ring appearance, all those things will be very clearly seen in an high resolution CT chest.
Yes, sir.
Okay. And why do you get that signet ring in bronchiectasis? What is the reason behind?
So the airway expands like 1 to 1.5 diameter. The airway diameter is increased, sir. And there is like mucus insinuated in the bronchus, sir. So because of that, it looks like a signet ring, sir.
What is that signet?
Signet,
A ring is your destructive airway.
yes, sir.
Okay. Signet is the
Mucus plug.
corresponding
Mm.
bronchial artery. Okay. Fine. You are able to follow.
Yes,
The
sir.
artery is your signet. The ring is your destructive airway. That is your destructive alveoli. Okay. So when you draw a ring with a signet, the signet will be the artery.
Yes,
And when you compare the size of the artery with the destructive airway, it is so bigger in size, so that you call this a signet ring appearance.
Yes.
Okay, so the cluster of grapes, tram track appearance, all those things are because of this only. Okay,
Yes.
fine, proceed.
Treatment, airway clearance, physiotherapy, postural drainage, nebulize with 3% hypertonic saline. We can give mucolytics like N-acetylcysteine, and we can give the patient azithromycin. It's a macrolide antibiotic. It's has a very good immunomodulatory action. So the patients can be put on for like 6 to 9 months of immunomodulatory action, and gentamicin, since the patient is having recurrent infection, can be given, sir.
Okay, so the mainstay of bronchiectasis is postural drainage. That is the first and foremost thing you need to understand. So chest physiotherapy, and have you seen the tri-ball spirometry? People will be either blowing or sucking the three-ball spirometry.
Yes,
So
sir.
that is called as tri-ball spirometry, where they can just stay at home and do a good physiotherapy for their lung. Okay, self physiotherapy. It is a very, very significant improvement when they start doing this tri-ball spirometry. Okay, because everybody will not be affordable to go and get a chest physiotherapy done. So they can just buy this and start doing even at their home. People, very poor family background, those who are not able to buy this tri-ball spirometry, is there anything else what you can teach them at their home?
So that we can teach them that exercise to drain the secretions, like.
Okay, that is one, but I'm asking which is equivalent to your spirometry, which needs your chest to expand well.
Blowing a balloon, sir.
Yeah, blowing a balloon. So you can just have a refill pen and sorry.
Thank you, sir.
You can just have a refill and start blowing your balloon.
Okay, sir.
Proceed.
That's over, sir.
Nebulizer, yeah, nebulizer and NAC.
Yes, sir.
Okay, fine. So the overall therapy is mainly chest physiotherapy and spirometry.
Yes, sir.
If you think you need to start on antibiotics, a third generation cephalosporin will be very, very helpful.
Yes, sir. Okay.
Otherwise, azithromycin and gentamicin, they are good antibiotics. You can use gentamicin with cautious because of renal toxicity. Okay. I think you have presented a very nice case presentation, including a detailed history, clinical examination, and you have almost answered all the questions, whatever that is asked in your exam. So very well presented case presentation.
Thank you, sir.
Species.
Mm.
Okay. Any other doubts they have? Nitish?
So till now in YouTube, only few have answered the questions, but they have not asked any doubts, sir.
Okay, fine.
Okay. Yes. Thank you so much for the session, sir. And that was a good presentation by Sumaya, and we hope we'll do more sessions in the future, sir. Thank you.
Yeah, sure. Thank you, Nitish, and thank you, Sumya, for your great presentation.
So thank you so much. It was very wonderful presenting to you. So it was a very nice experience.
Yeah, most of the questions will be directly asked even in your exam, whatever I have asked. So
Yes.
almost every question will be asked in your exam.
Mm.
Just follow the same questions with some more detailed explanation will fetch you very excellent marks.
Yes, sir. Okay, sir.
Okay, all the best.
Thank you.
Okay. Thank you, sir.